Now, regarding right bundle branch blocks, just a reminder, when we are looking at the heart, we have the lateral leads here, which are the lead 1, AVL, and lead 5, V5 and V6, right? They are looking at the heart from the lateral portion. And we have the precordial leads, which are V1 here and V2 here, looking directly anteriorly to the heart. Okay. And after that, we discussed that the electricity, when it reaches the bundle of Hess, will travel equally into left bundle branch and the right bundle branch, making both ventricles contracting at the same time. And at that time, we remember that the septum activation will be from the left to the right? And this will be, when we are looking at the heart laterally, the electricity is moving away in the septum, making a negative deflection at the beginning of the Kerr's complex, which is the Q wave. Okay, this is normally to be seen in the lateral leads. This is the normal thing. Now, what happens if I have a right bundle branch block? The right bundle is not working anymore. So initially, the left ventricle will contract normally. It will be activated normally. Thus, the initial part of the QRS complex will be normal. Okay, so if we look at the lateral of the precordial leads here, the precordial leads will detect the electricity once it reaches the left ventricle and will give the R wave. So we will have an R wave. Okay, and after that, there is a delayed activation of the right ventricle because now the electricity should move from the left ventricle to the right ventricle. And once it reaches the right ventricle depolarization will happen and will give us another R wave. So we will have this feature here, which is called RSR prime. Okay, this is RSR prime. It's just like the rabbit's ears, if you look at it like this. So this is a common feature seen on the precordial leads, V1 and V2. Okay, now if we are looking at the lateral leads here, let's have a look at the lateral leads here, which are lead 1, AVL, V5, and V6. What will happen? The electricity first reaches the left ventricle, so it will give the R wave normally. And after that, the electricity will travel away from these leads to the right ventricle. So the later half of the Kerr's complex will be delayed, and it will be slowly delaying and back to the baseline, making this slurred S wave. So this will be seen in the lateral. Okay, if we look at this EKG here, if you look at V1 and V2, and even V3 here, which is still precordial lead, you can find like R wave, after that deflection, negative deflection, and after that another R prime, because the electricity here reaches first the left ventricle, and after that there is a delay, and after that it will go to the right ventricle, giving us the RSR prime. Okay, if we look at the lateral leads, V5 and V6 here, and you can see the slurred S wave, in the lateral leads. So let's talk now about the criteria, all the criteria that make diagnosis of right bundle branch. We have 3 criteria. Number 1, Kerr's complex duration is product more than 3 small squares, which is 120 milliseconds. Okay, so this is number 1 because the electricity is traveling slower. Number 2, we see RSR prime pattern in V1 to V3, and we see a slurred S wave in lateral leads. These are the 3 criteria for right bundle branch block. Now, if the Kerr's complex duration is normal, that's being said, it's like less than 3 small squares, mean we can diagnose an incomplete right bundle branch block. It's not completely blocked. Okay, so this is the number 1 criteria to look for a complete right bundle branch block or incomplete right bundle branch block. Okay, now what are the causes of right bundle branch block? We have actually 3 most important causes. Whenever you see a right bundle branch block, you have to think about 3 things. Number 1 is right ventricular hypertrophy. Okay, especially if you have pulmonary arterial hypertension causing right ventricle to be hypertrophied. Number 2 is pulmonary embolus. If patient has a new onset of right bundle branch block and they have chest pain, hemoptysis, you have to think about pulmonary embolism. And number 3, which is the most significant one, is ischemic heart diseases. There is an increasing literature and like data in the literature says if the patient has chest pain and a new onset right bundle branch block, you have to think about complete closure of the coronary arteries. And sometimes in in proper settings, we can diagnose patients with non-STEMI, and those patients could have benefit from early revascularization, reperfusion therapy. And that's it.